afternoon. I can't thank you enough for the great honor of having the opportunity to come and participate in your conference. Thank you to Dr. Raju and the organizers, and congratulations on your 50th meeting of this conference. That's a great tribute to how much care you provided to the children. As I said, it's an honor to be here. What I'd like to do, what I was asked to do, is talk a little bit about our approach to complex esophageal disorders, mostly esophageal atresia, but also to address a little bit the collaborative approach that we take in Cincinnati. I am from Cincinnati, the Cincinnati Children's Hospital. For those of you who are not aware, Cincinnati is in southern part of Ohio, which is the eastern part of the Midwest in the United States. It's, I was saying at lunch to some of the residents, the entire service area of Cincinnati Children's is 2 million people, which for you is quite small, but it's actually the second biggest children's hospital in the United States and has 760 beds of just pediatric care. We have, over time, we have developed a very large research enterprise. We have a very nice endowment for our research, thanks to Procter & Gamble, and a gift that was given to the Children's Hospital in 1932. But what I'd like to talk about today is our esophageal atresia center. And this center was appended to an existing center, and for those of you who are familiar, this is a picture of our aerodigestive and esophageal team meeting, which occurs every Wednesday morning. And there in the center of the picture on the far side is Dr. Robin Cotton. Robin Cotton is a world-famous airway surgeon, and sort of characteristic of the collaborative approach, I approached Dr. Cotton and I said, I'd like to start an esophageal center, and he said, well, you should just append that onto our aerodigestive center. And he set some very, very important philosophical ground rules for the center as it operates. So you see in that picture, there are many people around the table, and the center includes many different subspecialties, but Dr. Cotton insisted that at that table, everybody is equal, whether you were a senior surgeon famous in the world, such as himself, or whether you are a resident or fellow, everybody had equal voice. And when we appended this esophageal center onto that, it was a wonderful way to bring that culture forward for these very complex patients. In Cincinnati, we tend to see a lot of very complex patients who are referral patients that come from other centers. As I said, our population in our primary service area isn't that big, so the only way we've been able to grow as an institution into the second biggest children's hospital in the country is to bring patients from outside of our service area. So we see a lot of referral patients. And this is where this collaborative team is very, very effective. The team itself consists of pediatric general surgery, such as myself, pediatric ENT, pulmonology, GI, not working. Okay, sorry. Pediatric pulmonology, GI, CT surgery, radiology, speech therapy, intensive care, as well as things like genetics, and we have a tremendous amount of support from advanced practice nurses. Sorry, audio issues. Is that better? Anyway, I'll continue. If it's not working, let me know. So for the trainees, this is a X-ray that provides people with lots of excitement and some trepidation when you get a belly film or a babygram, as we call it, on the patient, and it shows no evidence of air in the abdomen, which suggests the presence of a type A esophageal atresia. If our typical approach has been to put in a G-tube, and then after that matures a little bit, to get a gap study. And when the gap study looks like this, it's wonderful. It's very exciting. That's something that we are excited about taking to the operating room, and there's a good chance we can do a primary repair. It's much more intimidating when you get an esophagram that looks like this, and there's a very large gap between the proximal and distal ends of the esophagus. And this is where this multidisciplinary team comes into play. One of the research things that we've been working on in Cincinnati, it's always a challenge to know what the gap is. And until you put in the G-tube, you can't really do a formal gap study. But we have in our NICU a prototype MRI that allows us to do MRIs on resting babies without sedation, without anesthesia. And in doing those MRIs, our team has worked on how to segment out the esophagus and the airway. So we can actually look at this, shows a reconstruction of the airway in yellow, the proximal pouch in red, and the distal pouch in blue. And it's very interesting, as we've studied this, to look at what happens to the anatomy as you do the repairs on these children. So on the left side, the pre-repair, you can see that there's significant kinking of the trachea. That's pre-repair on a type C esophageal atresia. In the middle is immediate post-repair, and you see that that is straightened out somewhat. But on the right side, that kink in the trachea continues to evolve over time. And so one of the hot topics in pediatric surgery is whether you need to do a posterior tracheopexy at the time of the initial repair of esophageal atresia. And what we've learned through this is that the trachea, it's very hard to tell from a preoperative bronchoscope what the actual anatomy will be because it changes over time. The MRI we can do in a dynamic fashion so that we can actually see the tracheomalacia in a baby who's breathing spontaneously, in a newborn who does not require, as I said, any sedation or anesthesia. So this has been very helpful to us as we work to understand the anatomy. So what about the patients who have long gap or complex esophageal atresia? Historically, our approach, when I trained 100 years ago, our approach was as soon as we saw that, we would do an immediate esophagostomy in a G-tube, and we'd wait for the child to grow, and then we would do some type of replacement. And in Cincinnati, when I trained there, we learned to do colon interposition. However, the approach has actually modified significantly, especially over the last 10 years or so. And now there are multiple interventions that you can do to try to preserve the native esophagus. And so now it is actually quite uncommon for us to have to do a replacement for a pure esophageal atresia. Typically, the replacements we do are on these complex kids that have had multiple previous procedures, and the esophagus is not salvageable. This is a picture of the Fokker technique. It was described by John Fokker. I'm personally not a huge fan of the Fokker technique. It was, I believe intensely that traction does promote growth, but this procedure, which involves putting traction sutures in, bringing them out through the chest wall, and then sequentially tightening those sutures over the course of weeks. It works, but it has some significant morbidities associated with it. And this is a paper that Rusty Jennings and his group published back in 2015. And as you can see, those patients spend more than 2 months typically in the ICU. That's for the primary cases, and for the secondary cases, more than 3 or 4 months in the ICU, and a significant amount of that time paralyzed. More importantly, when you look to what are the results in terms of the ability of the child to eat, only 63% or 2/3 of the patients who have a primary Fokker procedure are actually able to eat. And importantly for us with this referral population, less than 10% of patients who have secondary operations are ultimately able to eat. So there have been lots of modifications essentially based on this traction theory. When I started doing this, we would just internally, we would do a thoracotomy, mobilize the ends, and if I couldn't get them together, we'd just tack them to the prevertebral fascia and wait for 6 weeks or so. We then modified that to bring sutures out and go back in a shorter time period, like a week or two, to try to pull the ends more closely together. This was a technique that was popularized by David van der Zee from the Netherlands and actually works very well. Subsequently, as we've adopted thoracoscopic procedures, this can actually be done internally with these sliding knots. Dariusz Patkowski from Poland has described this. This is a video actually of him doing this procedure, but putting these sliding knots in in the proximal and distal pouches, and then serially placing traction on them over the course of days rather than the course of weeks, to the point where you can then go back and do a primary anastomosis and preserve the native esophagus. However, this doesn't work all the time, and while this quote from 1974 suggests that you should do anything possible to preserve the native esophagus, I do believe that there are certainly cases where that is not in the best interest of the child. There are lots of complications. The child can't eat. They have multiple operations, which lead to scoliosis and other skeletal anomalies. And so I think that there are times when you should not preserve the native esophagus, and the question then is, what should you do? And as we all know, there are multiple options, and whenever there are multiple options, it means none of them are perfect or everybody would do the same thing. So it becomes a question of picking the least bad choice. And there are, as I said, you could do a gastric pull-up, you can do a colon interposition, you can do a jejunal interposition. Those are all options, but they all have complications. The International Association or Society for Esophageal Atresia, INOEA, the white paper that was written from that group suggests that a gastric transposition is should be your first option for replacement. The advantages of that are it's relatively fast. There are fewer anastomoses. There are 3 suture lines, but only 1 anastomosis. And so this is commonly what is done. Our gastroenterologists absolutely hate this procedure because they follow the patients long term and they have significant reflux. We've also had to reoperate on a number of patients where the stomach got so dilated in the chest that it actually caused a mass effect in the chest. So it's not perfect. So how about colon interposition? Like many things in pediatric surgery, it tends to generate a lot of controversy. There are many people who think that it is absolutely the worst possible choice, while others who think it's the best possible choice. The reality is they're all bad. This just happens to be one of the choices, and probably the best choice is the one that your service is most comfortable doing. So in Cincinnati, we focus on colon interposition. It can be very robust, has a great blood supply. We've, in caustic ingestions, brought it all the way up to the pharynx. It can be placed either in the posterior mediastinum, which is my preference, but if that's not available, you can put it substernal. You can also, in a couple of cases we've had where neither of those routes were available, we actually passed it into the left chest and brought it down around the hilum and pulled it back through the esophageal hiatus. You can use any part of the colon, and what I do is when I do a laparotomy, I evaluate the blood supply and decide which segment has the best blood supply and then use that for the interposition. I virtually never use the right side because I don't like the size discrepancy. I have a patient's mother who termed this the colophagus, and she still sends me pictures every year of her child on her colophagus anniversary. The challenge with colon interposition, as we all know, is that over time it can become distended and it can become elongated, causing this sort of sump above the diaphragm. We were taught, when I was a resident, I was taught that you can't do anything about that, but that's actually not true. It's relatively straightforward from the abdominal approach to take down the gastric anastomosis, mobilize the distal colon, the distal esophageal segment of the colon, and pull it down into the abdomen and relieve that siphon-type obstruction. So just quickly to review our experience over the past 10 years, as I referred to, a highly complex population, 56 patients. We excluded 1 because we did not have complete data. Overall age of 46 months, although up to teenagers, all had multiple previous operations. 2/3 of the patients were esophageal atresia, whereas 1/3 were from caustic ingestion, with a couple of other diagnoses. And then the procedure is residual esophagectomy with colon interposition using this team approach. And we often, or almost always, operate with the ENT surgeons working in the neck while we work in the abdomen, and it shortens the anesthesia and the time for the procedure. The complication rate, about 23% have a leak in the neck. and that resolves spontaneously in essentially all of them. It's just a matter of waiting. We have a fairly high stricture rate. Almost a third of patients developed a stricture. Virtually all of those but one were amenable to dilations. And then importantly, in terms of their ability to eat, the 25% were on PO only, to 36% were on a combination of oral feedings with enteral supplementations, and then almost a third of patients really did not eat at all. And just to quickly compare this is a study looking at comparison of colon interposition and gastric pull-up, and the conclusion of that study was that essentially both are satisfactory. However, there were more major complications in the gastric pull-up series. I think that's just a matter of if you look for whatever you want to find in the literature, you can find it. This is an important study. It was a meta-analysis from David Van Der Zee's group, looked at a very large group, 470 patients, 344, or 73% of whom had a colon interposition. And they also came to the conclusion that while both are reasonable, the colon interposition is a better choice. And then finally, an important study from my mind is this study from South America, in which they looked at long-term follow-up. And by long-term follow-up, this is 33-year follow-up, which is important. It's something we rarely do in pediatric surgery. And they found that 86% of the patients had a very good quality of life. So this, to me, is the really important thing, is the patient-determined outcome. So is it word bad, good, who knows? Ultimately, hopefully, science will fix this, and we'll have tissue engineering that will fix the problem. But until then, esophageal reconstruction can present some of the most complicated patients we see. We prefer a multidisciplinary approach. And then ultimately, tissue engineering or some other scientific advance will have to solve the problem for us in the long term. Thank you again so much for the invitation to come and participate in your conference.
Thank you very much, Dr. von Allmen. That is really a very good summary of what you do in your unit. I mean, there's no doubt that experiences from different centers, they seem to have different opinions on what is the best way to do it. But I think the one key message that we have to take away from here is a multidisciplinary team approach, because I think the whole team needs experience in dealing with a particular type of replacement. Otherwise, it's not going to work at all. So I think that message, is very, very important.
It really has I have learned a tremendous amount. When we started working with our airway team, our ENT surgeons, and we had a recurrent tracheoesophageal fistula, and Mike Rudder said to me, well, let's just divide the trachea and we'll get at it that way. And I was like, divide the trachea? You can't do that. And he's like, of course, we do that every day. And so it really, the most important thing is to do the right thing for the child. And I think bringing the expertise from all these different groups has been very helpful in that regard.
Any comments from the audience? Yes, please.
There's a brilliant talk. This is Raj from Newcastle. Have you tried in long gap esophageal atresia, the Cook device, to use the magnet? Recently, Sharif showed me that they had done 9 cases with a good outcome. So you use the Cook device to put the magnet on the top and the bottom, and then the esophagus joins together. I'm just wanting to share your experience on that.
We've had several experiences. If I understood your question, it's a little hard to hear about using the magnet for long gap. First of all, according to the company, it has to be within 4 centimeters, and we've tried it even at 4 centimeters, and it just falls out. More importantly, we've treated 2 cases from other centers that use the magnet, and the magnet caught the left bronchus when it closed, and so they ended up with a fairly severe bronchoesophageal fistula, which was difficult to repair, had to be repaired on bypass. So we've had 2 cases where the magnet has actually caused more complications than it's fixed. I think the utility of the magnet, we did a case with we did through a median sternotomy with a complex tracheal reconstruction, and the esophagus had been, I could not get the 2 ends of the esophagus completely together, but I was able to approximate them. But I didn't want to have to go back through the median sternotomy. So after the child healed from the tracheal reconstruction, we used magnets to create the anastomosis in the esophagus. But I knew that they were right next to each other and we weren't going to catch anything in between.
Thank you.
Very interesting talk, Dan. A couple of questions. How difficult it is to organize multidisciplinary team to get this work done, number one. And why colonic preference over stomach?
I'm sorry, Ranju, I couldn't understand your question because of the reverb.
How difficult it is to organize multidisciplinary team to get this work done smoothly?
Yeah, it's very difficult, and I'm very, very privileged to work in a center that facilitates that because ultimately we all work for the hospital. But on Wednesday afternoons after that meeting that I showed, we have combined time in the OR, and we all go to the OR together with the patient. So ENT will scope the patient, and then GI will scope the patient, and pulmonary will scope the patient, and I will stand there and we'll come up with a plan and then go talk to the family. They love that, but from a billing standpoint, it's hard on, it's very difficult to organize that. We're just privileged to work in a place where the hospital will pay for that.
Dr. Shailen.
Hello. Dr. Allmen, thank you very much for a very good talk. I must say, I personally have not done any colonic interposition, although I've been attending since 2001. But I took over from Miss Leela Kapila, who's contemporary of Catherine Anderson. Like when she was the APSA president, she was the BAPS president, and she was the vice president of college. So she used to do it, and I have assisted her around 10 cases, and when she retired, I took over that job. So I have followed those 10 cases over a period of 23 years. I'm counting my days as attending. And, as they say in surgery, one of the enemies of good outcome is long-term follow-up. And I've done the long-term follow-up. And I can tell you, no problems. So although I wasn't trained enough to do it, and I know Catherine Anderson used to do it, and these two ladies were the BAPS and APSA president, but they were very fond of colonic interposition. So I know it's a lost art, but I think it's a great thing, and I can tell you from a personal experience. And on a second note, I have seen plenty of total gastric transposition, which Louis Spitz does in Great Ormond Street for us, because it's all centralized. Yes. But I end up doing the follow-ups. All have issues. Thank you.
Thank you very much for your comments. Again, I think you get used to what you get good at what you're good at doing, but there are many options, and this has some of the advantages that a gastric pull-up does not.
So my question is related to your technique. I would like to learn that when you are doing cologastric anastomosis at the distal end, would you like to place the conduit anterior or posterior?
I actually tunnel the graft behind retrogastric, so bring it behind because that gives me the most length on the blood supply. And again, I tailor it depending on where I think the blood supply is best. I'd like to put it in an isoperistaltic fashion, but the reality is it doesn't really matter. So sometimes it's antiperistaltic. But then I sew the distal end of the colon interposition to the anterior wall of the antrum of the stomach.
And the second question is regarding the corrosive stricture esophagus. 1/3 of the patients in your series who needed colonic interposition had corrosive stricture. Would you like to leave the strictured segment, or you would do esophagectomy?
We try to do, or I was going to say always, never say always. We do an esophagectomy in 99% of the cases. We've had a couple of cases where there were multiple tracheoesophageal fistulas, and we thought we would not have a trachea if we took that down. So I actually left the native esophagus in place. We divided it proximally. I did a very tight Nissen distally because I didn't want there to be reflux. And then we did the colon interposition in a substernal location. We then counted on the fact that those tracheoesophageal fistulas stayed open so that the child would cough out whatever mucus formed in that nearly isolated esophageal segment.
Thank you.
Thank you very much.